Hello, today I'm going to talk about sustainable surgical volunteerism. This is my experience over the 3.5 decades that I've been involved with surgical volunteerism. I share my experience and an evidence-based approach to design, develop, and deliver structured and sustainable surgical volunteerism in areas of need. First of all, I'd like to thank a few people. Professor Kenneth Mark, who's currently the Director General of Health at the Ministry of Health Singapore, who, when he was the chairman of the medical board at Khoo Teck Puat Hospital, he provided the 2 weeks of unrecorded leave for me to do this surgical volunteerism, and for which I'm appreciative, and the continued leadership in Khoo Teck Puat Hospital, who continue to provide this period of time of unrecorded leaves so as I'm able to perform this surgical volunteerism. And one of the places where we did a lot of research and we developed models for sustainable and ethical delivery of surgical care and training is Dr. Jim Gollogly, who is from the CEO of Children's Surgical Center in Cambodia that we have been going through for the last 11 years. There have been various organizers of such missions, especially in Sri Lanka, Bangladesh, India, and Indonesia, that have organized and invited us to do the similar sort of surgical volunteerism, for which we are grateful. We started off, I personally started off in this journey in 1986 when I had just come back following training in orthopedic surgery as a surgeon through the work of the late Professor Kanda Pillai in Singapore, who was then working with the World Orthopedic Concern and the Shaw Foundation, where we started going for 2 week stints at Ujung Pandang, Sulawesi, to provide training and also to deliver care. I'm also grateful for BAPRAS UK, the Plastic Association, who has helped us in terms of supporting with resources. And most of all, I'd like to thank the team members, the various members of team from the UK, from Malaysia, and also from obviously Singapore, who have been fundamental and pivotal in delivering this. The Global Surgical Survey 2030 that was reported in the Lancet shows that there's $12.3 trillion economic losses as a result of inadequate care in surgery globally. There are more than 143 million procedures that are needed globally, and yet there is no resources available. So this is a big problem. And therefore, if you look at what the paper suggested, there were various causes that result in an inadequate surgical care. And if you look at the right top corner, this is the area where surgical volunteerism can help because of the insufficient workforce, the lack of trained surgeons, and insufficient anesthetic care to be able to provide a good service through training of the locals. The literature provides us with evidence that there is a growing trend of volunteerism among the medical profession. There's a high motivation, however, there are challenges in terms of time constraints and logistical challenges. However, there's a lack of structured programs, and there is also a general motivation being of egocentric, as most surgeons tend to be quite egocentric. Short-term missions are bound to fail, and I think should not be recommended, and I don't think they are ethical or moral because they do not meet the needs of the community in which they're attempting to serve. There is a requirement for a structured program that encourages local surgeons to be trained to be able to provide the service, and this needs to be taken into account in any program. However, there is a challenge of volunteer tourism, and this is not ethical and it's harmful. In 2011, we did a literature review, and then we did a survey of among clinicians in the United Kingdom, and we're very encouraged, and we published this in the BMJ, that there's a very high willingness to commit time. 83% were willing to commit their time, and 74% believed that and had participated in some form of volunteer activity. And I think that shows the evidence in the literature. We also looked at our experience in delivering surgical care through training in Cambodia, and we published this in a journal with our experience at the Children's Surgical Center in Cambodia. These are the key takeaways from our findings: that sustainability was only possible through training of local surgeons for independent practice. And we built the capacity building in the capacity for surgical care locally, and that led to the sustainability, and this was possible because of collaboration between the local and international faculty. The impact of medical volunteerism is significant. There's improvement in healthcare outcomes, and we have evidence, and I will share with you some of our evidence of how this has happened. So it is a very fulfilling task. The challenges were that there were language barriers, there were resource limitation, but however, with the use of technology today, we are able to overcome this through the use of online learning modules, teleconferencing, and now generative AI can provide intelligence support system and decision support system for the local surgeons. However, there are ethical and financial considerations that needs to be taken. There need to be a commitment and a financial commitment of surgeons who want to do this volunteerism, and it's not cheap. You have to commit and sacrifice financial resources to be able to perform. These were the findings of our study. Now, if you look at the WHO's and the United Nations Sustainable Development Goals for a Better Planet, you notice that surgical volunteerism fulfills 4 of the major Sustainable Development Goals, 3, 4, 10, and 17. And therefore, this is a good strategy for a better planet. And I think this should be one of the professional requirements of a surgeon. This rise in surgical volunteerism has been as a result of the altruistic calling that is innate among most physicians. We take up medicine not for the sake of our own self, but because of our desire to alleviate the suffering of our fellow humans. And I believe that this is an important component of professional growth in every surgeon, that they need to learn how to use their skills and resources in diverse contexts. The transformative impact of surgical volunteerism is amazing, and it is quite addictive, I can tell you, because of the satisfaction as you see local surgeons are able to perform, and some of them even better than you. And the cultural exchange is excellent, and I think it's very satisfying. It allows for us to be able to use our resources in countries that are low in resources. How does the surgical volunteerism bridge the gap? It provides a surgical expertise with the volunteer surgeons to be able to deliver care, but at the same time, it allows for knowledge and skill sharing and transfer of this to the local surgeons. This allows for the ability for sustainable surgical care in low and middle income countries. The volunteers help by not only coming and providing the services, but help to gather resources in terms of equipment and including finance. By the process of this relationship and culture over long-term periods, it's possible to create advocacy and indeed produce policy changes in the regions that we work. Now, the successful models based from our experience, especially in the paper that we publish, and I'm quite biased towards this, is this, that you really need to have capacity building, you need an integrated approach, and there must be a targeted intervention. And we use a very evidence-based approach in the sense of we looked at the needs of the community, both the patients in the community and the surgeons, and then provided bespoke intervention in the form of training, resources, and assessment, and making sure that the local surgeons were up to mark. The challenges that we faced in our activity was the cultural sensitivity. We must understand the culture and the society that we are working with, not only of the people, but of the surgeons. Surgeons are always very suspicious, but they may not voice or articulate this. It took 1 year before the local surgeon in Cambodia accepted us, because when they found that we were genuine, we were authentic in our desire to pass knowledge. The logistical coordination is extremely important, and this is where the local partners help us in terms of arranging for time and resources to allow local surgeons to be trained. Long-term sustainability is only possible through building relationship with local ownership of the program, and it's beyond the volunteers' intervention and requires the role of the local surgeon. Ethical practice is extremely important, and I think this is especially so for some of the surgeons who come who think that they are going to improve their skill set by operating on the locals. The locals have the same rights and responsibility and requirements as those in which you practice. You practice the same portfolio that you practice in your country of origin as you would there. You require the same amount of audit, you require the same amount of peer review, and this is crucial. Developing a sustainable surgical volunteer program requires sound instructional design and technology principles, educational principles to be able to transfer technology. As in any other training program, you require a needs assessment to be able to understand the needs of the community, the types of cases that are seen, and the surgical competencies and the skill sets of the local surgeons. We, in our first visit in Cambodia, did an audit of 1,000 cases that was operated in the center, and we were able to identify through a Pareto analysis the surgical needs, and we also interviewed all the local surgeons to find their surgical gaps and to identify those, and then created bespoke training programs both from knowledge and skills levels and professionalism. These were then used as a resource and intervention to increase their skill sets and their knowledge to build capacity, and through which we provided knowledge transfer and skills transfer. These were done through various workshops and direct observation of procedure and skills training. Now, this is only possible through the cultivation of behavior and attitude towards altruism as being part of the medical profession. Equitable partnership with local institutions are crucial so that they can identify the local surgeons who then we look at and evaluate their skill sets and then design bespoke intervention programs for them. The ethical practice is very important, that we continue to maintain a high level of ethical practice so that the locals will understand that we are genuinely interested in their needs. We have to be careful to understand the economic constraints, the logistic constraints of the local patients, that we must do surgical procedures that may not be identical indications that we would use in our own area of practice because their needs are different. Identify the psychosocial, the economic needs of the individuals before offering types of surgery. This requires a lot of experience, and therefore in the team members you must have very experienced surgeons who have the ability to give what the patients need and not what you want to give them. Long-term thinking is absolutely important. We are here for the long game. Minimum of 5-year commitment is required, because that's what we found in our case study, that at least by the end of 5 years, the local surgeon was sufficiently competent to be able to be independently practice using the skill sets that we have developed for them. What is the future of surgical volunteerism? I believe the collaborative partnership is one of the important aspects, and here is where the national bodies from the what I call the developed surgical communities need to be engaged, involved, to ensure that there's ethical training, ethical practice, and the transfer of surgical skill to the local surgeons. Technology today is going to help us tremendously, especially with generative AI. We can create intelligence support system, decision support system, and with asynchronous communication, we are able to provide support and scaffolding for the local surgeons to continue to practice after we have left the community. Advocacy and policy change is important, both from the donor surgeons and the donee community. So the donor countries need to make sure that they understand this, set up systems and frameworks and regulation in place so that surgeons follow ethical practice that are evidence-based in the area in which they're doing it. Local policies in the recipient countries needs to be there to ensure the security of the visiting surgeons, to ensure that they are able to deliver, provide resources, and most important, provide surgeons who are able to continue in their training to be of sufficient level to provide safe care to the patients. These are some of the work that we did. When we did the analysis, we found 5 areas which there were need for surgical expertise. One was in the brachial plexus surgery, as this was a country in Cambodia where there are a lot of motorcycles, and so we started off creating a skill set by running the first microneural workshop in Cambodia, and we got 12 microscopes, and we identified surgeons who could do microsurgery through the process of training. We then found there were a lot of tendon injuries, and so we create tendon workshops to give them the skill sets of performing tendon repair and tendon reconstruction, and these were augmented by cases that they had seen in the clinic, and we guided them through the process until by the end of the training they were able to perform independently. One of the challenges was the language, so we used identified targeted local surgeons who spoke well bilingually English and in the local language, and we provided support through live and online. The ability of having online digital resources meant that we could easily translate them to the local language. Now with generative AI, this can be done very quickly and easily and rapidly deployed so that they have the resources to have the knowledge and skills. We then also found there were a lot of deformities in bone, and so we ran a fracture fixation workshop to give them the skills, and we used some implants that were affordable for local use. To try and do a train-the-trainer program, we identified and targeted a few of the local surgeons, and we trained them on the use of technology to provide training. So we taught them on how to use online modules, the creation of videos using simple software, and to help host their various resources and various platforms so that they were universally accessible for free by the community. What do we do now? And I think it's important that if we think and talk about surgical volunteerism, this must be all moved into action. I strongly believe that there should be a national surgical volunteer program. This is to be monitored by the regulatory bodies of the donor nations, who would therefore have formal government endorsed programs where they may be given resources in terms of unrecorded leave, to provide them with incentives to perform this, and this should be part of the KPI of professions of surgeons, so that it is included into their practice. There need to be a formal partnership between the donee countries and the donor countries so that they can be focused on long-term structured capacity building and training. Ongoing education is crucial, and mentoring can be done even remotely with the use of current technology. For Singapore, I think the medical education infrastructure is very strong, and this should be utilized to bring in surgeons from overseas, from these donee countries, to be able to attend targeted training. We have done this in Khoo Teck Puat. In-person workshops and online resources are extremely helpful, and I think surgeons, and every time as you are doing your cases, think about how you could create open educational resources using technology and make them available so that the surgeons can use these resources remotely and continue to be able to deliver care. Telemedicine and remote mentorship programs are excellent, and now with the use of smart glasses, we can provide remote expert supervision and mentorship while being locally available, because the smart glasses only need to be worn by the novice surgeon or the trainee surgeon in the LMIC, whereas the expert surgeon can be in his home, and this is very useful. We're currently working on an ongoing program to look at the usability and utility of these devices. And I think it's useful, especially in Singapore, where this can be part of the Global Surgical Fellowship, where Singaporean surgeons can be sent to LMIC as part of their training to understand and include that into their portfolio of practice. And there must be audits and peer review to ensure that the surgeons practice to a high level in the countries in which they have gone to provide training and capacity building. Thank you for listening, and I'm happy to be of help. If anybody would like to reach out to me, I'm happy to help you with your practice of surgical volunteerism to make it meaningful for others and for yourself. Thank you, and good luck.